So your team is ready for the topics and presentations?
Yes, I checked up with them just before the meeting.
Okay. All right, then when you are ready, go ahead. Hi, everyone. Thank you for coming to this meeting, and Lina will lead the Zoom meeting today. Thank you.
Let me just check if Mihir is online with us today. I don't see him in the participant.
He's joining just now, so give him a second.
Okay.
So I'm going to share the...
Good afternoon, everyone. Welcome to Red Team meeting today. We have 3 presenters with us. First topic is gait impairment with Mihir, and second topic is heart failure by Humaira, and third one is research methods with Ashwani. I'm pronouncing it right. Hope you will enjoy this meeting.
Thank you. So, Mihir, if you are ready, you can share your slides, if you have slides.
Sure.
Sure.
Hello, everyone.
Hello.
Okay, you can see your slides.
Can you see my slides?
Yes, we can.
Okay.
Yes, pretty clear.
Okay. So today we are going to discuss about gait and gait impairment. Well, I feel like gait is just one of the elements we, in our routine practice, we work on part of the mobility. When as a physical therapist, when we actually assess the patient, especially it depends upon the settings, but in long-term care or in skilled nursing facility, we overall look for mobility. So it's not just gait, but there are a lot of other elements as well. So with this today's presentation, we also be able to describe how to perform a diagnostic evaluation, how to perform of gait dysfunction, how to conduct a gait assessment, and of the older adults, and understand intervention that can possibly reduce the impairment. So let's look at some basic understanding of gait epidemiology, gait assessment, condition that contributes to gait impairment, intervention to reduce gait disorders, and some case studies. Just a minute. Let me this. So sorry about that. So when we talk about, as I said earlier, gait is not just one portion or one thing we assess. Part of the mobility, there are gait, locomotion, balance, falls, all involved, and they are all interrelated. So if we see about gait, the definition is, it is a manner in which a person walks, mostly characterized by rhythm, cadence, step, stride, and speed. Locomotion is the ability to move from one place to another, means it can be by walking from one place to another, or wheeling or propulsion in a wheelchair from one place to another. The next one is balance, the ability to maintain the body in equilibrium with gravity, both statistically, or that means while stationary, or dynamically, that means while moving. And next one is falls. Falls, as per CMS, Center for Medicare and Medicaid Services, it defines as unintentionally coming to rest on the ground, floor, or other lower level, but not as a result of overwhelming external force, like if resident is pushing the another resident and cause a fall, that's not considered as a fall. An episode where a resident lost his or her balance and would have fallen if not for staff intervention, is also considered as a fall. So gait, locomotion, and balance problems often involve difficulty in integrating sensory, motor, and neural processes altogether. Falls, balance, they are all bigger topics. I can speak on all those topics all day long, but unfortunately, due to time constraint we have here today, that's for another day. So let's move ahead and let's talk about Gait Cycle analysis. There is a very short video, and I think everybody can, sorry, let me just do this. And I think it's very short, like 4 or 5 minutes of video, which will give a detailed on the elements of gait and analysis.
In this video, I'm going to talk about the basics of the gait cycle and gait analysis.
I'm going to pause for a second and I'm going to actually put into the YouTube. So that gives a more bigger picture. Can anybody see this YouTube video?
That can keep up. That's what.
Can you guys see this video?
Yes.
Okay.
I can see your screen, but I can't see the video.
Okay, let
Maybe it's my
me.
connection.
Just
Hi,
sorry.
and welcome back to Physio Tutors. Gait analysis can be part of your function.
Let me try again. Sorry about that.
Hi, and welcome back to Physio Tutors. Gait analysis can be part of your functional assessment. You will most likely choose to do a gait analysis when, for example, walking was one of your patient's specific complaints that you have recorded during history taking. When you do a gait analysis, it is wise to look at the patient from the front, the back, and the side. It can also be beneficial to record the gait analysis on video, to show it in slow motion, and to discuss your findings with your patient. So let's take a look. Before we start getting into the analysis itself, let's talk about the gait cycle. We are going to focus on the right gait cycle, meaning we're going to follow the right leg during a full stride. We should begin by defining.
Sorry.
In this video, I'm going to talk about the. Take a look. Before we start getting into the analysis itself, let's talk about the gait cycle. We are going to focus on the right gait cycle, meaning we're going to follow the right leg during a full stride. We should begin by defining steps and strides. A step starts with the initial contact of one foot and ends with the initial contact of the other foot. A stride starts with the initial contact of one foot and ends with the next initial contact of that same foot. So it's made out of 2 steps. Now let's begin by looking at the 2 phases of the gait cycle. First, there's the stance phase. It accounts for 60% of the full gait cycle. During stance phase, the right foot is always in contact with the floor, hence the term stance. In the swing phase, which makes up 40% of the gait cycle, the right leg is, you guessed it, swinging. Now let's look a bit closer. During stance phase, the right leg has to complete different tasks. With the heel strike, the leg has to accept the weight of the body. This so-called loading response marks the first 10% of the gait cycle. The loading response ends once the contralateral foot lifts off the ground. We are now in single limb support. Here, we can differentiate further. After load response, up until the point of heel off, we are in so-called mid stance. So far, we have reached 30% of a full gait cycle. The heel of the right foot starts to lift while the contralateral leg has initial contact with the ground. This period is called terminal stance. We have reached 50% of the gait cycle, and we are almost through stance phase. While the contralateral leg is proceeding to make full contact with the ground, the right leg lifts off further off the ground. This is the so-called pre-swing, and we have reached 60% of the gait cycle. Stance phase is now complete, and we start the swing phase. The only task now is right limb advancement until the next heel strike. We subdivide the swing phase into the initial swing from toe off until the feet are adjacent. We are now at 73% of the gait cycle. Following initial swing is a short period called mid-swing, and it lasts until the tibia is vertical. We have reached 87% of the gait cycle. The last period, the so-called terminal swing, ends with the heel strike of the right leg. Take a look at this overview. You can download a full resolution picture in the description down below. To analyze gait in physiotherapy, one could make use of the Nijmegen Orthopedic Gait Analysis form. You can find the article in the description down below. It's a checklist to assess certain aspects of the body during gait, and it's important to compare left and right. You would ask your patient to walk at his or her normal pace. Kai is walking at 3 kilometers an hour, which is an average walking speed. A general aspect to assess is whether there is a shortened stance phase or not. It's usually the most obvious deviation from normal gait. For example, a patient who is limping will have a shortened stance phase for sure. Focusing on the trunk, check whether the trunk is anterior or posterior to the hips, or if lateral flexion is present. In some patients, the arm swing might also be reduced. Next up, one should look at the pelvis and whether posterior rotation is excessive. Your patient might have to expose landmarks for you to assess this item. At the hips, check the amount of extension and whether that is reduced. Do the same for the knee. Also, assess the knee flexion movement and check whether it's absent. Furthermore, check for normal ankle plantar flexion, which might be reduced. Lastly, you could also inspect the amount of internal or external rotation of the leg. All right, this marks the end of the video on gait analysis. If you enjoyed it, make sure to give this.
Okay. Next one is changes in gait with aging. So most predominant one is decreased gait velocity or gait speed and stride length, and increased stance width and increased double support time. Means keeping both legs on the same time and the same on the floor increase with the aging process. Now, epidemiology. Gait disorders are common and predictor of functional decline. Certain gait-related mobility disorders progress with age and are associated with morbidity and mortality. Community dwelling older adults with gait disorders, particularly neurological abnormal gaits, are at higher risk of institutionalization and death. Now, speaking of neurological abnormal, can anyone tell me what cranial nerve, damage to what cranial nerve actually affects the gait? Or just put down in the comment section, please. Yep, that's right. 8 cranial nerve. Thank you. Now, next one is a glossary of gait abnormalities. So term antalgic gait means pain during ambulation, usually limping with shortened stance phase of gait or painful side. Next one is circumduction, outward swing of leg in a semicircle from hip. equinovarus, which is excessive plantar flexion and inversion of ankle. Fascination is an acceleration of gait. Foot drop, loss of ankle dorsiflexions, secondary to weakness of ankle dorsiflexors. Actually, foot drop most commonly occurs because of the nerve palsy. Foot slap, early frequent audible foot floor contact with steppage gait compensation. Most of the time, foot slap occurs and can be seen in hemiplegic patients with spasticity of the plantar flexor muscles, which doesn't allow to do the initial gait like a heel contact, as it was seen in the earlier in the gait analysis. Freezing of gait is more like a sudden short duration diminution or cessation of walking, usually associated with a shift in attention or movement's circumstance or direction. Next one is glossaries. Next one is genu recurvatum, which is a hyperextension of knee. Propulsion, tendency to fall forward. Retropulsion, tendency to fall backward. Scissoring, hip adduction such that knees cross in front of each other with each step. Steppage gait is exaggerated hip flexion, knee extension, and foot lifting, usually accompanied by foot drop. Trendelenburg gait is shift of trunk over the affected hip, which drops because of the hip abductor weaknesses. Turn and block is moving the whole body while turning. Can anyone put into the comment section where in which condition we see turn and block more often? If anyone has any idea. That's right, Parkinson's. Thank you. Now, there are common disorders which affects in primary care. Usually we see multifactorial, like degenerative joint disease, acquired musculoskeletal deformities, intermittent claudications, orthopedic surgery, stroke, postural hypotension, dementia, fear of falling, visual loss. Now, may classify by abnormal sensory motor level. There are 4 phases to that. Low peripheral sensory dysfunction. Another one is low like a peripheral motor dysfunction. Middle is postural and locomotor impairment. And higher one is cognitive and white matter disorders. These levels may overlap when certain disorders involve multiple levels like Parkinson's, involving cortical and subcortical structures. Now let's look at those conditions and clinical findings and abnormalities. Peripheral neuropathy or proprioceptive deficits, usually loss of touch sense, loss of position sense, which occurs with a possible steppage gait, wide-based, unsteady, uncoordinated, especially without visual input. And it may lift feet high and slap on the ground to increase sensory feedback. Vestibular disorders like disequilibrium, abnormal Romberg, waving, or more like a drunken kind of symptoms we can see, falling to one side. Visual impairment with visual loss, tentative, uncertain, uncoordinated gait. Painful or deforming conditions with pain and decreased motion of hip, knee, or spine. Signs of arthritis, thoracic kyphosis, decreased lumbar lordosis, and stooped postures, which commonly comes with the antalgic gait with shortened stance phase on affected side, Trendelenburg gait, buckling of painful limb, and with weight bearing. Focal myopathic neuropathic weaknesses has proximal muscle weakness, distal muscle weaknesses, exaggerated lumbar lordosis. Trendelenburg gait can be seen, waddling gait can be seen, with steppage gait with a foot drop or foot slap. Now we'll see cerebral ataxia with poor trunk control in coordination or cerebral signs. Wide base with increased trunk sway, irregular stepping, staggering, especially on turns. Parkinsonism, rigidity, bradykinesia, tremor, stoop posture, small shuffling steps, hesitations, fascinations, propulsions, retropulsion, turning and block, absent arm swing, freezing of gait. In hemiplegia or hemiparesis, we can see arms and leg weaknesses, spasticities, equinovarus, genu recurvatum. Gait abnormalities can be like leg circumductions, loss of arm swing, foot drag or scrape. Paraplegia or paraparesis, we can see leg weakness, spasticity with a bilateral leg circumduction, scraping feet, possibly also scissoring. If we see cognitive and white matter disorders, more like a frontal lobe diseases, dementia, normal pressure, hydrocephalus, with cognitive impairment, weaknesses and spasticity, urinary incontinence, gait abnormalities such as range of findings may be like difficulty in initiating gait, freezing, legs, apraxia, and shuffling gait, similar to that seen in Parkinson's disease, but with wider base, upright posture, and preservation of arm swing. In dementia, mid to late stage dementia may have fear of falling, cautious gait with normal to widened base, shortened stride, decreased velocity, and block turns. Next one, gait assessment. There are a few key points. Certain medical histories and physical exam can elucidate contributing factors. Laboratory and diagnostic imaging may be warranted depending on history and physical exam. Use a gait assessment tool such as timed up and go, TINATI performance-oriented mobility assessment, dynamic gait speed, dynamic gait index. Then establish a person's comfortable gait speed, used as both assessment and outcome measures. Remember that most gait disorders are associated with underlying diseases. Next, evaluate for evidence of subacute metabolic disease, acute cardiopulmonary disorders, and other acute illnesses. Attempt to identify motion-related factors like by provoking both vestibular and orthostatic responses. For such an example is Dix-Hallpike test for vestibular dysfunction, supine and standing blood pressure to exclude orthostatic hypotension, vision screening at least for acuity, which is essential. Evaluate neck, spine, extremities, and feet for pain, deformities, and limited range of motion, particularly regarding subtle hip or knee contractures. Measure leg length discrepancy, such as can occur with hip prosthesis and either as an antecedent or subsequent to lower back pain. Simply measure the distance from the ASIS, which is anterior superior iliac spine, to medial malleolus of tibia. A formal neurological assessment is critical. Assess strength and tone, sensation, including proprioception, coordination, including cerebral functions, station, and gait. The Romberg test screens for simple postural control and whether the proprioceptive and vestibular systems are functional. Given the importance of cognition as a risk factor, assessment of cognitive function is also indicated. CBC, laboratory and imaging assessment. CBC can helpful. Serum chemistries, other metabolic studies may be useful when systematic disease is suspected. Head or spine imaging, including radiography, CT scan, or MRI, are not indicated unless history and physical examination identifies neurological abnormalities, either preceding or of recent onset related to the gait disorders. Now, when we perform the performance-based functional assessment, comfortable gait speed and related endurance measures such as 6 minutes walk test are powerful predictors of falls. Sorry, I lost it. Sorry about that. So usual gait speed is tested from a standing start over a distance of 4 meters. A speed of 0.6 meter per second has been proposed as cut point for this mobility. Speeds of more than 1.0 to 1.2 are associated with better functional outcomes and increased life expectancy. Now, we have discussed about the timed up and goes test in the previous meeting. Just simply record the time it takes the person to rise from a chair, walk 3 meters or 10 feet, turn, return to sit into the chair. One study suggests a tuck score of more than or equal to 14 seconds as an indicator of fall risk. Others have found limitations in tuck test in the presence of cognitive impairments and difficulty in completing the test due to immobility, safety concerns, or refusal. Now let's see another one. Intervention to reduce the gait disorders. Many conditions causing gait disorders are at best only partially treatable. Other outcomes such as pain reduction may be equally important in justifying the treatment. Comorbidity, disease severity, and overall health status tend to strongly influence outcome. Functional improvement becomes the treatment goal. Exercise and physical therapy. It can be very helpful in knee osteoarthritis to improve strength, flexibility, and aerobic exercises, particularly with a single goal. And when provided at least 3 times per week, it shows at least some moderate effects in improving overall function. Also in post-stroke or any like CVAs, treadmill training may improve gait speed and walking endurance. Electromechanical and robotic assistance may increase likelihood of walking. Parkinson's disease, PT, including complementary treatments, yields short-term gains in functional mobility and gait speed. Many surgery can also be helpful to improve gait, such as in lumbar stenosis. Many have reduced pain after laminectomies and lumbar fusion surgeries. However, non-operative treatment can also result in modest improvements such as walking tolerance. NPH may have short-term, NPH means normal pressure hydrocephalus, may have short-term gait improvement after shunt placement, but the improvement may not be maintained long-term. Hip knee replacement for OA, pain relief, sizable gains in gait speed and joint motion occur, although residual walking disability may continue. Multidisciplinary rehabilitation after or prehabilitation prior to joint replacement may have positive effects. Now, various mobility aids such as lifts like internal or external to correct limb length inequality used in a conservative, gradually and progressive manner. Ankle braces, shoe inserts, shoe body and sole modification can be also helpful. Walking shoes with low heels, relatively thin firm soles, and if feasible, high fixed heel collar support can be helpful. Canes and walkers can reduce load on a painful joint. Light touch on a wall or furniture surfing provides a feedback and enhances the balance. So what we learned so far is gait disorders are common in older adults and are predictor of functional decline. The cause of gait impairment in older adults is usually multifactorial. So full assessment must include consideration of a number of different causes like determining the detailed physical examination and the functional performance evaluation. Various interventions ranging from medical to surgical to exercise can reduce the degree of impairment, although some residual impairment is often present. So here's some case scenario. First one is a 78-year-old man comes to the office accompanied by his daughter, who is concerned about his frequent falls. She says that he tends to fall when he is away from home. He does not fall often in his house. The patient is unconcerned about the falls. The examination shows blood pressure and heart rates are normal, including postural responses. Visual, vestibular, and peripheral sensations are normal. Muscle strength, motion, and endurance are normal. There is no rigidity or abnormal resistance to passive motion of joints. Gait speed is 1.18 ms. He steps with no difficulty over an obstacle placed in his path with a few small steps on approach. He does not make appropriate adjustment to maneuver past furniture in the exam room or past other people in hallway. So let's see the next slide. Which of the following is most likely to be a factor in his fall? A, cognitive dysfunction, B, cerebral dysfunction, C, Parkinson disease or Parkinsonian syndrome, or D, spinal stenosis. Please put your answers in the chat box. Well, those who answered A is the correct answer. Congratulations and thank you. So let's see the next slide. So cognitive dysfunction is the answer. Next question is, next case scenario. An 82-year-old man is concerned that his activity is increasingly limited since he fell 6 months ago, and after he suddenly lost his balance, he is reluctant to go out socially for shopping or lunch. Since his fall, he has had several near falls despite being very careful. He reports no dizziness or unsteadiness when he sits. At home, he holds onto furniture for support and confidence. History includes osteoarthritis, diabetes mellitus, hypertension. He had bilateral total hip replacement. Right one was done 5 years ago and left one was done 2 years ago. Examinations reveals the blood pressure 148/78 mmHg, heart rate 72 breath per minute. He uses his arms to stand from a sitting position. He is mildly lightheaded for less than or equal to 30 seconds when he first stands. Visual acuity 20 out of 30 at best correction, normal hearing and cognitive and cranial nerve findings, no Romberg sign noted. Vibratory sense diminished bilaterally in gait toes and ankles. Strength normal except in hip abductors. 4 out of 5. Glossary graded unchanged since exam 4 months ago. He walks without an assisted device at a speed of 0.63 ms. Base of support is wide. He takes small steps. There is no Trendelenburg gait pattern. He has difficulty in turning and walking along a curved path, but not when he walks a straight path. He occasionally reaches for the rail in the hallway. Left finding shows the hemoglobin A1C 8.2%. So which one of the following is the strongest contributor to his gait impairment? A, hip abductor weaknesses, B, peripheral neuropathy, C, orthostatic hypertension, D, cognitive impairment. Please post your answer in the chat box. Those who have answered B, peripheral neuropathy is correct answer. Because of the history of his diabetes mellitus, neuropathy is likely cause of the patient's gait impairment. His gait is characterized by short steps, slow speed, and difficulty in turning. So persons with neuropathy often increase their base of support and become more cautious because they have diminished proprioceptive input from the feet. Now, next case scenario. 78-year-old man is seen for follow-up related to gout in the right first metatarsophalangeal joint. He has not had gout pain for 2 weeks. He fell in his home twice in the last 2 weeks when doing his regular activities. He did not lose consciousness and does not know why he fell. He was not injured. History includes hypertension, bronchitis, osteoarthritis. He walks barefooted at home to avoid pressure on his right first MTP joint, and he is wearing sandals only. Upon examination, supine blood pressure 146/78 mmHg, heart rate 85 breath per minute, O2 saturation 95%. After standing for 3 minutes, blood pressure 135/76 mmHg, heart rate 90 breath per minute, and O2 saturation is 96%. Intact cognition, sensation, and visual fields. Visual acuity corrected with bifocal lenses. Dix-Hallpike maneuver negative for dizziness or nystagmus. Range of motion normal except for stiffness at the end range for hip flexion. Strength is 5/5 for all lower extremity major muscle groups. Bilateral hallux valgus with no redness, swelling, or tenderness of right first MTP joint. Gait speed is 1.1 ms. Which one of the following intervention is likely to decrease his overall risk of falls? A, prism to improve peripheral vision. B, treatment of orthostatic hypertension. C, referral to a community-based exercise program. Or D, footwear modification. Please answer, post your answer in the chat box. Thank you. There are a lot of mixed answers I can see here. B, D, and C. Let's see. I think the correct answer is D, footwear modifications. Improper footwear is associated with falls in older adults. Study shows that older adults often wear slippers or socks or walk barefoot in home. Sandals generally offer little support and may be similar to walking barefoot. Prisms are used to improve peripheral vision, particularly for persons with homonymous hemianopsia, a condition that results in visual field cuts on the right or left side. Affected persons may bump into people or objects on the side of the deficits, which may lead to the increased accidental falls. These patients' visual fields are intact, and history and examination finding do not support this cause. Let's see for C, a lot of people answer C. Orthostatic hypertension is defined as a 20/10 mmHg drop in blood pressure when moving from supine to standing position. Ideally, the second blood pressure measurement should be taken 2 minutes after the patient stands. Although this patient's blood pressure drops when he stands, the changes does not meet the criteria for orthostatic hypertension. Additionally, the patient's history does not include lightheadedness, dizziness, or loss of consciousness, and his falls do not occur when he stands. So, community-based program, exercise program may benefit this patient for fall prevention, but the first intervention would still be to modify his footwear. Any questions? Thank you so much.
Thank you, Mihir, for this presentation. It was really informative. If anyone has a question, please raise your hand.
Thank you so much, Mahir. This is great.
Thank
and
you.
To the point. Thanks.
Thank you for having me. Thank you so much.
Appreciate it. So we see a lot of patients who might have trouble falling, going to the hospital with fractures or with other conditions, and they have some weaknesses here and there, so they may need some rehab. So when they come to the rehab center or the nursing home, they spend few weeks or months, and then they get better, stronger, and then they go home. So Mahir and his team usually work with them, so they do evaluation, and one of them is the gait and balance, as he mentioned. Thank you. So I'm gonna ask, we have few new fellows joined us recently, and I just want to make sure everyone knows we almost closed for new fellows, but these are the last ones, and I'm gonna ask them to go ahead and present or just talk about, maybe introduce themselves, just a little bit background about you guys. Maybe Jamila, go ahead.
Hi, everyone. My name is Jamila from Minnesota.
Nice to have you. And we have Arij Ahmed, I think. Just a brief introduction if you have anything to add.
Hello.
Assalamu alaikum.
My name is Arij Ahmed from Connecticut. Nice to meet you.
Nice to have you all. And I think we have Rawan.
Hello, everybody. Rawan Ahmed. I'm from California. And thank you, Dr. Nader, for giving me this opportunity to join this program. I'm looking forward to learn and participate. Thank you.
Thank you. Welcome all. And I think we have Hina Zubair. So we have technical issues, I think, with the voice, with the sound. Maybe you can try later. Hi, yes, go ahead.
Yeah, hi, Dr. Nader. My name is Hina Zubair, and I am a graduate of Rawalpindi Medical University, Pakistan. And currently, I'm living in Toronto and preparing for step 3 as well. And thank you so much.
Thank you. Thank you. Welcome and thank you. Anyone else I missed?
Hi, everybody. My name is Shaza Hassan. I'm from Ohio. Thank you so much, Dr. Nader, for give us this great opportunity to be in this program. We really appreciate your help and support. Thank you once again, and good luck for everybody.
Thank you. Thank you so much, everyone, and welcome. And anyone else? If anyone jump ahead. If not, Lena, you can go to the next agenda item.
Okay, if we have no question for me here, we can proceed to our next topic. Humaira will be presenting a heart failure today with us. She's also a new fellow. This is her first time presenting in this fellowship. And go ahead, Humaira.
Hello, everyone. Can you hear me properly?
Yes, we can, and we can see your screen.
Yes,
you can see my screen as well. Okay, thank you so much. So I'm Humaira Kausar, and I'm currently in Chicago. So just a little background about me. I finished my medical graduation from India, and I'm calling in from Chicago. So today I'm going to discuss about heart failure in geriatric population. Okay, yeah. So coming to the objectives, today we're going to learn about the epidemiology, the etiology, the pathophysiology of heart failure, also the clinical signs and symptoms of heart failure as they manifest in older adults, appropriate management strategies, and how to provide end-of-life care with consideration of individual patient prognosis. The topics which we're going to cover separately: epidemiology, etiology, pathophysiology, clinical features in the diagnosis, management, recurrent hospitalization reasons, prognosis, and end-of-life care. Coming to the epidemiology of heart failure, we know heart failure affects more than 5 million Americans out there, and more than 5.5 million new cases are diagnosed each year. So that's why I would say incidence and prevalence increases with age. Leading cause of hospitalization and rehospitalization in older adults. Median age of patients hospitalized with heart failure is 75 years, and approximately 2/3 of deaths attributable to heart failure are in patients aged 75 or older. Heart failure is a major cause of chronic disability and impaired quality of life in older adults. Coming to the etiology, heart failure in older adults is often multifactorial in origin. Hypertension is the most common antecedent cardiovascular condition in both men and women. So hypertension is the principal cause of heart failure in 60 to 70% of women. In men, 30 to 40% of heart failure is attributable to hypertension, and a similar proportion is attributable to coronary artery disease. Other common causes could include valvular heart disease, non-ischemic dilated cardiomyopathy, or even hypertrophic cardiomyopathy or restrictive cardiomyopathy, and even pericardial disease. Coming to the definitions, there are two types we know. The first, systolic heart failure, which is heart failure with reduced left ventricular ejection fraction. Up to 90% of heart failure patients who are less than 65 years old have this form of the disease. The second type, which is heart failure with preserved ejection fraction greater than 50%, these affect 40% of men and 2/3 of women greater than 65 years old with heart failure. Coming to the symptoms and signs of heart failure. So usually the classic presentation of heart failure in younger patients is tachycardia, narrowed pulse pressure, increased JVP, pulmonary crackles, diminished breath sounds, pitting edema. So that's basically the classical symptoms, but these symptoms are not specific in older population. So they usually present with atypical and non-specific symptoms. The most common ones are exertional shortness of breath, fatigue, orthopnea, and leg edema. Exertional symptoms may be less prominent in older adults because of a more sedentary lifestyle, and the prevalence of atypical symptoms increases with age. Decreased mental acuity, confusion, lethargy, irritability, anorexia, and abdominal discomfort or altered bowel function can also be one of the symptoms. Coming to the diagnosis of heart failure, we know whenever a patient comes in with shortness of breath, the first test we do in the hospital is a chest X-ray. So standard chest X-ray remains the most useful initial test for detecting pulmonary congestion and pleural effusion. It can also exclude pneumonia as a cause of shortness of breath in that patient. B-type natriuretic peptide is more specific, and its precursor N-terminal pro-BNP are valuable in establishing the presence of heart failure, and in particular in distinguishing shortness of breath due to heart failure from that attributable to non-cardiac causes. But here again, the specificity decreases with age. What are the other tests we can do? We can do an EKG, technically speaking, to rule out acute ischemia, MI, or maybe atrial fibrillation, or look for left ventricular hypertrophy. And apart from that, we're going to do routine tests like CBC, blood chemistry levels, troponin levels, creatine kinase, just to rule out other causes. Coming to the management of heart failure. So once we know the patient has heart failure, it's most important to determine the cause and then to assess the left ventricular function, because that's how we're going to come back to the original way of treating it. So the goal mainly is to decrease symptoms and to improve the quality of life, reduce acute exacerbations requiring rehospitalization, and also increase the survival. Hypertension, hyperlipidemia, and diabetes should be treated aggressively in accordance with current guidelines. Smoking cessation should be strongly encouraged and supported if needed, and alcohol intake should be limited to no more than 2 drinks per day in men and 1 drink per day in women. Let's start first with the non-pharmacological therapy. So we know the basic things like restrict the dietary sodium intake to less than 2 grams per day. Most patients with heart failure should also engage in regular exercises such as walking, stationary cycles, swimming, and water aerobics. But again, exercise duration and intensity should be adjusted to the individual patient level of conditioning. It can't be one rule for all. Every patient has a different level where they can go up to. Patients should also keep an ongoing record of their daily weight. So basically, how do we check for a weight? The weight should be obtained in the morning without clothing, often after going to the bathroom, but before having breakfast. That is known as a dry weight. And the patient is usually told that whenever there's a difference of more than 2 to 3 pounds above or below the dry weight, then they should immediately contact their physician. Coming to the pharmacotherapy of systolic heart failure. Optimal treatment requires more than 3 medications, and in some cases, up to 7 medications as well. Almost all patients take 1 additional medication for coexisting illnesses. Main problems include adherence, high potential for drug interactions, adverse events, which are very common in geriatric population, and the cost itself. So therapy must be individualized, taking into consideration the multiple factors that influence quality of life and other desirable clinical outcomes in older adults with multiple chronic illnesses and limited life expectancy. Let's start with ACE inhibitors. So angiotensin converting enzyme inhibitors. In general, start treatment at the lowest dose and gradually titrate to the maintenance dose as tolerated. What are the contraindications for using this? If you know the patient has intolerance to these agents or hyperkalemia, severe renal insufficiency in patients not currently undergoing dialysis. Common adverse events, we know the most common one is cough, which occurs in 5 to 10% of patients during long-term treatment, and mild worsening of the renal function, which is often transient. Hyperkalemia can also be an adverse event, along with hypertension and GI distress. When do we consider the ARBs as an option, angiotensin receptor blockers? So when a patient is unable to tolerate the ACE inhibitors due to the following adverse effects I mentioned, like cough, allergic reactions, and GI disturbances, then that's the time we should consider an ARB. Coming to beta blockers. As with ACE inhibitors and ARBs, treatment should be started at the lowest available dose and gradually titrated to the maintenance dose over several weeks. Again, everything has contraindications. For beta blockers, they include severe decompensated heart failure, active bronchospastic lung disease, marked bradycardia, relative hypotension, significant atrioventricular nodal block, and known intolerance to beta blockers. Now, diuretics for systolic heart failure. We know it's an essential component of heart failure therapy in most patients, and most effective agents relieve the congestion and edema as well. In general, diuretic doses should be adjusted to maintain euvolemia, manifested by the absence of pulmonary rales and S3 gallop, increased JVP, hepatojugular reflux, and peripheral edema. Some clinicians recommend serial BNP level monitoring just to maintain the level of, just to see whether they are euvolemic, and around 100 to 200 is indicative of an optimal intravascular volume. Now, coming to aldosterone antagonist. The aldosterone antagonist, like spironolactone, has been shown to reduce mortality and hospitalizations in patients with NYHA class 3 and 4, and especially with patients with ejection fraction less than 30. The selective aldosterone antagonist like eplerenone has been associated with improved outcome in patients with recent MI, which are complicated by heart failure or who have an ejection fraction of less than 40. As I mentioned, Nyh classification, let's just go through each of the classifications. So we have 4 classes. Class 1, no symptoms and no limitations in ordinary physical activity, that is shortness of breath when walking, climbing stairs, etc. Class 2 includes mild symptoms with mild shortness of breath and angina and slight limitation during ordinary activity. Class 3, marked limitation in activity due to the symptoms even during less than ordinary activity, such as walking a short distance like 20 to 100 meters, and they are comfortable only at rest. Class 4 includes severe limitations, experience symptoms even while at rest, and mostly the patients who are bedbound. Coming to other therapies for systolic heart failure, digoxin improves symptoms and reduces heart failure hospitalizations in patients with chronic systolic heart failure, but has no effect on mortality. The adverse events include nausea, visual disturbances, and cardiac arrhythmia. There's a combination of hydralazine and nitrates, which can also be used. But when is this used? When a patient has contraindications to ACE inhibitors as well as ARBs, or a Black American patient with advanced heart failure, then we will consider using hydralazine and nitrates combination. Coming to the pharmacotherapy for patients with preserved ejection fraction, there is no optimal therapy. It depends on the situation of the patient. But what are the current recommendations? Aggressively treat hypertension, other risk factors, manage comorbid coronary artery disease, maintaining sinus rhythm or effective rate control in patients with AFib, judicially use diuretics to maintain euvolemia while avoiding overdiuresis, because the patients who are in heart failure, they are really volume sensitive. Coming to the implantable cardiac defibrillator, ICD, as we know it, it reduces mortality from sudden cardiac death in patients with systolic heart failure with ejection fraction less than 35%, regardless of the ischemia or non-ischemic heart failure. Prophylactic placement is advised for patients with NYHA class 2 or 3 heart failure with ejection fraction of less than 35 and life expectancy of more than 1 year. When do we defer the ICD implantation? After 40 days, if a patient has an MI, or after 90 days, after a new diagnosis of dilated cardiomyopathy. So in the latter case, because left ventricular function often improves after initiation of beta blocker and ACE inhibitor therapy. Coming to cardiac resynchronization, this is basically a biventricular pacemaker wherein one lead is placed in the right ventricle and the second lead is inserted in the coronary sinus in order to stimulate the left ventricle. This is indicated with patients with dysynchronous left ventricular contraction, most commonly related to left bundle branch block, present in up to 30% of patients with systolic heart failure. This improves symptoms, exercise tolerance, quality of life, and survival in selected patients with advanced systolic heart failure and persistent severe symptoms like patients in NYHA class 3 or 4, despite conventional medical therapy. Now, recurrent hospitalization. This is a big issue. So up to 50% of patients with heart failure are readmitted within 3 to 6 months after the initial hospitalization. Patients who experience recurrent heart failure hospitalization within 3 to 6 months after an index admission should be questioned carefully, mainly about the adherence to medication regimen, use of over-the-counter medications, recent changes in weight, recent dietary choices, and daily fluid intake. The most common causes of readmission is non-adherence, okay? And apart from that, dietary sodium intake, fluid recommendations, and other things we can consider is poor social support, failure to seek medical attention when the symptoms worsen as well. Coming to the prognosis. Median survival rates of 2 to 3 years, which is really unfortunate. 25 to 30% of patients die within 1 year after initial diagnosis. 50% patients survive up to 1 to 5 years. And then 20 to 25% survive for more than 5 years. So women and patients with heart failure with preserved ejection fraction have somewhat better survival rates than men with patients with systolic heart failure. And other factors that adversely affect the prognosis include more severe symptoms like higher NYHA function class, or lower systolic blood pressure, or presence of other underlying coronary artery diseases. And especially in women, diabetes also plays an important role. Coming to end-of-life care. Counsel regarding an advance directive, durable power of attorney for healthcare, and explicit instructions about what interventions they would and would not wish to undergo if death appeared imminent. Ask patients with ICDs to indicate under what conditions they would want the ICDs turned off to avoid repetitive painful shocks at the end of life. In patients with particularly poor prognosis and remaining life expectancy less than 6 months, frank but empathic discussion should be undertaken with the family and patient. So basically, in light of poor prognosis of older heart failure patients, we would consider more than the most common forms of cancer. And specifically, if their life expectancy is less than 6 months, we can also consider palliative care and hospice. It should be offered to them. So as a summary in whole, heart failure is the leading cause of hospitalization in older adults and a major source of chronic disability. Older patients with heart failure are more likely to be women and more likely to have preserved left ventricular systolic function. ACE inhibitors, ARBs, beta blockers, and aldosterone antagonists reduce morbidity and mortality from heart failure with reduced ejection fraction. Optimal medical therapy for heart failure with preserved ejection fraction is undefined. Optimal management of heart failure in older patients often requires a multidisciplinary approach. So now let's go through a couple of cases. So my first case is a 78-year-old man with no significant medical history comes to the ED with severe chest pain for 3 hours duration associated with shortness of breath and diaphoresis. Initial Ecg findings are 4 to 5 mm ST segment elevations in the precordial leads, V2 to V5 and 1 to 2 mm ST segment depression in the limb leads, that is 2, 3, and AVS. On emergency cardiac catheterization, it reveals 100% occlusion of the left anterior descending artery just after the first large septal branch. Percutaneous coronary angioplasty with insertion of a stent into the LAD is successful. So the peak troponin level is 8.6. So that's pretty high because the normal level is up to 0.4. The hospital course is complicated by mild heart failure that resolves with diuresis. Pre-discharge echocardiography reveals anteroapical hypokinesis with mildly decreased left ventricular systolic function and an estimated ejection fraction of 45%. So coming to a few lab values, on the day of admission, his total cholesterol was 186 milligrams per deciliter, HDL cholesterol was 47, LDL cholesterol 113, and triglycerides 130. Okay, coming to the question now. In addition to aspirin, statin, and clopidogrel, which of the following are appropriate discharge medications for this patient? Would it be a beta blocker and a nitrate? Would it be a beta blocker and spironolactone, non-dihydropyridine calcium channel blocker and an ARB, beta blocker and ACE inhibitor, non-dihydropyridine calcium antagonist, and long-acting nitrate? So A, B, C, D, and E. So please answer in the chat box. Okay, So thank you for your participation. I see maximum number of people answered D. And let's see if that's correct. Yes, it is. So it's beta blocker and ACE inhibitor. So just a description about it. We know aspirin and beta blockers have shown to reduce mortality following acute MI in patients of all ages. And of course, clopidogrel is also indicated after an acute coronary intervention. ACE inhibitor is appropriate in patients with acute MI complicated by heart failure. So that's why we consider beta blocker and ACE inhibitor really useful in this case. Coming to the next case. A 72-year-old woman comes to the ED with palpitations and shortness of breath for 2 hours duration. Her history includes hypertension, mild restrictive lung disease, gastroesophageal reflux disease, and positional tremor. She says she was sitting in a chair when she noted the sudden onset of heart racing, followed by a few minutes later by difficulty breathing. She reports no chest pain, diaphoresis, dyspnea, or syncope. When the symptoms did not resolve after an hour, her son brought her to the emergency department. On examination, the patient is in mild respiratory distress. Her heart rate is in between 130 to 150 beats per minute and is irregular. Blood pressure is 140/70 and respiratory rate is 22 breaths per minute. Her neck is supple with normal jugular venous pressure and no thyromegaly. Lungs are clear. Heart is irregular with 2/6 systolic ejection murmur and no S3 or S4 gallops. She has a moderate positional tremor. ECG findings would show atrial fibrillation with rapid ventricular response, left ventricular hypertrophy with repolarization abnormality, but no ischemia changes. A chest X-ray was also done showing mild cardiomegaly. Adenosine thallium stress test shows left ventricular ejection fraction of 67%. Echocardiogram shows moderate left ventricular hypertrophy, mild left atrial enlargement, normal left ventricular systolic function, and mild left ventricular diastolic dysfunction. Coming to some labs, cardiac markers are normal. Creatinine is 0.8, BUN is 17, hemoglobin is 13.1, hemoglobin A1C is 7.3, thyrotropin is 2, total cholesterol 198, HDL cholesterol 55, LDL cholesterol 113, and triglycerides 150. The patient is treated with IV diltiazem with subsequent reversion to sinus rhythm, about 85 beats per minute. Intravenous furosemide results in net diuresis of 1,160 cc, and her shortness of breath resolves. So basically, she has improved. MI is excluded by normal serial troponin levels. Now, coming to the main question. Which of the following are appropriate discharge medications for this patient? Is it aspirin, warfarin, amiodarone, and ACE inhibitor? Is it warfarin, diltiazem, beta blocker, and ARB? Is it an aspirin, beta blocker, ACE inhibitor, and a statin? Is it D, warfarin, beta blocker, ACE inhibitor, and an ARB? Or is it E, diltiazem, beta blocker, ACE inhibitor, and a statin? So A through E, please answer in the chat box. So thank you for your participation. So everyone answered C. So yes, that's right. So C is the answer. So basically, we're looking at the CHA2 score over here. The patient has hypertension, due to which she has a CHA score of 1. So in this setting, either aspirin or warfarin is acceptable for thromboprophylaxis. Since there is no evidence that warfarin is going to be beneficial, you will just, because AFib usually responded or resolved spontaneously within the 24 hours. So aspirin is an appropriate choice in order to decrease the lower risk of bleeding complications. And of course, we have to give beta blockers because of it helps in the mortality. And of course, other things like ACE inhibitors and statins go with it. I wanted to mention one thing, the data from Heart Outcomes Prevention Evaluation, that is the HOPE study, and the Heart Protection Study indicates that older adults with diabetes or vascular disease benefit from routine treatment with an ACE and a statin. So that's why we were considering these two as well. And thank you so much. That is all from my side. And any questions, anyone? Why not warfarin again? Okay. So basically, when considering aspirin and warfarin, the AFib usually resolves spontaneously within the first 24 hours, and there is no beneficial thing showing that warfarin will be better in this case. So that's why we preferred aspirin. Hope that answers your question.
Thank you, Humaira, for this presentation.
Thank you so much.
Thank you
I
so
think there
much.
is a raised
This is great. Yeah.
Yes, thank you so much for this presentation. I have a question. If we go back for case 1, I just want to know when will be the use of spironolactone in a patient of heart failure.
Second, let me just share my screen again. So you're saying in question number 1, right?
Yes.
So you're saying why not spironolactone? You're saying why not B?
Yeah, or when we will use it, when we will use the spironolactone in a patient with heart failure.
So basically, I guess the value, that's what's mentioned over here. The value of aldosterone antagonists such as spironolactone is unknown in patients with acute MI and preserved left ventricular systolic function. That's why we are not considering spironolactone here.
So you said when there is a patient has acute MI, complicated with MI, is that mentioned in the previous slide?
So what I mentioned is if for in case a patient with an acute MI and preserved LV systolic function, usually in that case, and use of spironolactone is not unknown. I mean, it's not caused any beneficial effect. That's what I'm saying.
Oh, okay. All right. Thank you.
Okay, you're welcome. Okay, thank you so much.
Thank you.
Thank you so
It's a
much.
great presentation. Thanks.
If there is no other question, we can proceed with the agenda. Our third topic for today.
I saw a question in the chat regarding the use of angiotensin, ARBs, neprilysin combination for heart failure. So it's just interesting question. So if you go through it, this will be better for us.
Yes, this is a question by Ala Abdus-Samad. How about angiotensin neprilysin inhibitor as a first line for heart failure? I think I will pass the question to either Dr. Nader or Dr. Humaira.
So if Dr. Humaira come across some answers, jump ahead. If not, I'll answer.
Yes, please go ahead, Dr. Nader.
Actually, we
I would
use
love
the
to know.
in case
I
of
would love to know
reduce
the answer as
electrical
well.
action to reduce the.
Nafisa, you want to add something? You're
Yes, I said usually we use those medication in case of patient heart failure with reduce ejection fraction in order to decrease the load for the heart.
Thank you so much. Hopefully this answers the question. Khulud?
Yes, thank you. Thank you for a great presentation, Dr. Maher and Dr. Humaira. Just about this new approach or I'm not the intervention of angiotensin neprilysin inhibitor as asked by Dr. Ala. I'm just asking Ala if she has any new updates or anything she can share or she can explain.
Yes, actually for me, I think the heart failure is we have a steps to, to add in a way to treat the heart failure. For example, like first we start with a combination of angiotensin neprilysin inhibitors in addition to the beta blocker and the diuretics. And if this not work, then we go with the aldosterone inhibitors. And then if it's not work, then we have a new thing, which is the sodium cotransporter 2 inhibitors also, as it's need to the loss of the sodiums and water, which is it works as a diuretics as well. This is, I think, the new update for the treatments of the heart failure, in addition to the loop diuretics for the what is that called, shortness of breath or the volume overload. And yeah, I think so.
I think we use, if I may allow the chance to speak.
Sure. Please go ahead, Dr. Muhammad.
Yeah, actually in our ICU, we use this new medication, which is Entresto. It's a combination of sacubitril, which is a neurolepsin inhibitor. That actually, neurolepsin is an enzyme naturally responsible for the degradation of brain natriuretic peptide and atrial natriuretic peptide, which are normally secreted from the atria and the ventricles in the brain in response to volume expansion and volume overload. So I think the first trial was to, introduce a synthetic neurolepsin, I think a synthetic PMP, but then they found that this PMP and AMP was degraded fastly and removed from the circulation, leading to the discovery of this neurolepsin enzyme, which degrades down the PMP and AMP, and thus the development of this inhibitor, which is sacubitril. The drug name is Entresto, I think, which is combined sacubitril with valsartan at the dosage of, I think, 50/25 to 160 of valsartan, and the limitation to use it is hypotension. Unless the patient is hypotensive, then you can go ahead. Sometimes we cut the dose to half, sometimes we give the full dose. And the other medication which is introduced recently is empagliflozin and dapagliflozin, which are antidiabetics, were initially developed for the targeting diabetes, but then were found to have enormous benefits in cardiac events, I think, and survival rates in diabetics and non-diabetics, and now are also part of the regimen we use for heart failure with reduced ejection fraction. This is my experience with heart failure. I admit patients daily in our ICU having heart failure. Thank you.
Oh, thank you so much.
Thank you so much.
To Ala, this is very informative. Thank you so much.
Thank you, Dr. Muhammad, for your contribution. Khulud, do you have something to say, or this is just raised from previously?
Thanks for previous contribution. Thank you so much, Lena.
Okay. No other raised hand. We will go forward with our third topic is research method. Ashwani, you can go ahead if you are ready. Start sharing your screen.
Hi, Lena. I think Dr. Mohammed has a question. He raised the hand. Dr. Mohammed, please go ahead.
Yes, I want to add something regarding sacubitril valsartan. Actually, I came across very nice information regarding this medication today during my preparation for step 3 exam. Because this medication inhibits the breakdown of brain natriuretic peptide, it said that it is not reliable to depend on brain natriuretic peptide to assess whether the patient is having cardiac dyspnea or not. Because with this medication, BMP or brain natriuretic peptide is definitely going to be high. So this is the information I want to add for you, doctors. It is not reliable to depend on BMP in patient taking sacubitril valsartan.
I see. Thank you so much, Mohammed. It was a very nice point.
Thank you.
Hello, everybody. So I'm just going to share my screen. Okay. Please let me know if you can see the screen.
Yes, we can
Thank
see
you.
your screen.
Thank you so much. So today's topic is clinical research methods. Let's dive in. Research methods that I have organized is to give you a brief introduction, talk a little bit about case control studies, and talk about confounding, moving on to cohort studies and randomized control trials. So throughout our lives, we are exposed to many factors that can affect our health and well-being. But what kind of factors influence specific health outcomes, and what do we do when we become ill? Health researchers dedicate their working lives to answering a huge range of different clinical research questions, and they do so by carrying out very specific studies. The findings from these studies eventually lead to the development of interventions that can help save lives, and that's what we're going to study about. The types of research, to make it easy for us, we have differentiated into two distinct types of research: quantitative and qualitative. The two groups use both set of research methods, like they do come into each other, but there is a little difference. Let's see the difference. What's qualitative research? Quality, we are going to talk about who, what, how, when, and why is this happening. Just to understand the nature or quality of a phenomenon, like why did this phenomenon happen? When did this phenomenon happen? So these can be as observational, or you can interview, you can have focus groups, or we can even do surveys. In the sense of observation, we mean of what is happening in the community. Just look through the community, get the data, and observe. Interview is we are going to form questionnaires, we are going in depth or key informant interview. We are going to ask them a lot of questions and get answers. Moving on to focus group, we are going to talk to a group of people. The group of people can be deceased or non-deceased, doing aerobics. So we are going to choose the group of people where there is something in common. Or we can even conduct surveys. This is for a quality research. Going on to quantitative. So the name itself says the quantity is how much. To understand the magnitude of an occurrence, like incidence rate, how many people are affected. For example, if there is a gastroenteritis outbreak, we are going to ask how many people have gastroenteritis. So we are going to answer the incidence rate. And we are going to form an association between a risk factor and an outcome. Like, did they go out to eat somewhere, get the risk factor and form an association. There are two types of quantitative research, interventional and non-interventional, quite easy. So intervention is whenever a physician or a doctor or a researcher comes in between and intervenes in the trial. One of the example is randomized control trial, in which the double-blinded, where the researcher as well as the participants, nobody knows who is going to get the drug or what kind of a drug did they get. Did they get a drug or a placebo? So everyone is blinded. That's double-blinded. Non-interventional is something like observational. We are just watching and seeing what is happening. You are not going to intervene. You are not going to give medicine, or you're not going to give some exercise therapy, anything. We are just not going to intervene. We are just going to allow it to flow as normally. It's further divided into 4 types now. That's our main interest: cross-sectional, case control, cohort study, and ecological study. So, just a second, I cannot see the whole thing. Okay, so now this is just an overview of all the designs that we are going to talk about. The very first step is, did the investigator assign an exposure? If the investigator assigned an exposure, we said it's an experimental study. Was this allocation randomized? If it is yes, we call it a randomized control trial. If it wasn't randomized, we call it a non-randomized trial, but it is still an experimental study. Now, going on to the other arm, did the investigator assign an exposure? No, he did not. So we call it an observational study, right? We are just going to observe. Was a comparison group used? If we used a comparison group, we call it analytical study. Was the starting point for the research? Is it an exposure? Is it an outcome? Or exposure and outcome together? If the starting point was an exposure, all of us know it's a cohort study. If the starting point was an outcome, we call it a case control study. If both exposure and outcome are considered together, we call it a cross-sectional study. Now moving on to the other arm, if the comparison group was not used, we call it a descriptive study. And what direction was it taken? Are you reporting it? Are we measuring it? If you're measuring, we do a cross-sectional study. If we are reporting, we call it a case report, case series, or a case study. If you're all good with this, I can move ahead.
Yes.
Okay, thank you. Yeah. So now case control study. So we said, what is a case control study? We are going to start with the case. Start with a group of case or an outcome. This is the best study for rare diseases because you're picking up the rare disease as the case. So that's the best. Get similar group called controls, similar characters, but they do not have an outcome of interest, right? That's what is controls. And we are going to look back retrospectively and try to identify the exposures. The exposure here can be single or multiple that may have led to this rare disease. And what are you going to do? You're going to determine if there is a difference in exposure among the two groups. The thing is, it's inexpensive. That's very good about it. It's faster and easier to look back than going forward in time, taking so many years. It's easy to look back. The biggest drawback is the evidence is weak. It's not a strong association. It doesn't explain causality. This is about our case control study. So if you see case control study in the picture here, we have cases, right? And we have controls. Cases are disease of interest. Controls are just group of people with similar characters, but no disease of interest yet. If you go back in time, we are following them back retrospectively, you can classify them as exposed and unexposed to a certain risk factor. Similarly, we do for the controls as well. We go back in time retrospectively and we classify them based on the exposure as exposed and unexposed. Now, if you see the cases, most of them, the orange color girl, the green dressed girl, and the one with the coat, and the one with the pink shirt, all of them came in cases. But we do have a person with the orange shirt who came from unexposed. If you look at the controls, we have a tall man, a lady, and another lady, a person with a wheelchair. All of them came from unexposed, but we do have a lady who came from exposed group. So what this is trying to say is, doesn't mean all the cases are from exposed itself, and doesn't mean all the controls are from unexposed. We can get them from either groups, and this is what we are going to help in stratifying using the case control study. Okay, now which clinical questions does this study best answer? Case control studies are best used for prognosis questions. For example, do these anticholinergic drugs increase the risk of dementia in later life? Right? So you are going to take the cases, go back in time and check, was the drugs helpful? So there is a study already done with anticholinergic drugs and the risk of dementia. It's a case control study. It's one of the research paper. Now, the advantages of case control study in detail are, it helps you find the source of an existing illness or an epidemic. It is cheaper, less expensive, quick to conduct this type of study. The health issue has already occurred. You don't need a lab or a special equipment. Few ethical issues as the patient already has the health condition. Looks at multiple risk factors in a patient's life, like in environment, work, diet. We can look at many factors. Now, the disadvantages, patients' recall about their history can be inaccurate. So we have to deal with the recall bias. Patients are aware of certain risk factors. They may focus on those and ignore other exposures. No randomization is possible, lowering internal validity of the study. Very important. It lowers the internal validity of the study. Finding a control group that matches the case group appropriately can be difficult, right? We cannot match everything because they are already diseased, the cases and the controls. We have to match them in all respect except for the risk factor and the disease factor. Now, the study type does not provide a clear causal relation between the risk factor and illness, and it only calculates the odds. So that is why whenever we study a case control study, we say the odds of developing a disease is this much. We do not say the risk is this much. We just say the odds. So that was about case control study. Now going on to confounding, because it's in relation to the case control study, a lot of it. So confounding occurs when the elements of the study design invalidate the result. They say that it is not a valid result. Why? Because it's usually unintentional. It is important to avoid confounding, which can happen in a few ways within the case control studies. This explains why it is lower in the hierarchy of the evidence, but it is superior only to the case studies. If the health issue causes multiple common exposures, the study should attempt to differentiate between those exposures to identify which one is more likely to have caused this. For example, you have a chronic illness. You may mean to spend more time in the hospital environments. They have a lower immune system and suffer with high level of stress. So any of these could potentially be the cause of the chronic illness. The study must try to eliminate some of these exposures as cause if it's possible. If the control group is overmatched and starts to develop the health issues, that can be another confounding. If the control group is undermatched and there aren't enough comparable factors to differentiate what is specific to this particular case population. For example, if you could not find a female control to match the female cases, then you cannot assess whether gender is or isn't a contributing risk factor. So this is about confounding. Moving on to cohort studies. Cohort studies are longitudinal observational studies which investigate predictive risk factors and health outcomes. So cohort is for risk factors. Remember, case control was odds. Cohort is risk factor. They differ from clinical trials in that no intervention, treatment, or exposure is administered to the participants. The factor of interest to researchers already exists in the study group under investigation. Study participants are observed over a period of time. The incidence of the disease is the exposed group is compared with the incidence of disease in the unexposed group. Because of the observational nature of the cohort studies, they can only find correlation between a risk factor and disease rather than the cause. Determine if there is a difference in exposure among the two groups. That's what we are trying to find out. Now, for example, this is a prospective cohort, means we are going to go forward, right? So we have, you are going to screen for healthy people. The investigator is going to take a study sample from the population and she is going to screen the healthy people. If people have existing illness, that's in the past. Now you're going to go forward in time to the future, looking at what exposure status. Are they exposed? Are they not exposed? Now, exposure, did we get an outcome? Look at the outcome. Are there any new cases in the exposed group? Are there any new cases in the unexposed group? So this is what is known as prospective, going forward in time. Retrospective cohort is the investigator is at the present time and she already has cases, new cases. She already has outcomes. Now she is going to go back and see, was this person exposed? Were they not exposed? So then we are going to stratify them exposed to the risk, not exposed to the risk. This is retrospective, historical. The advantages of cohort study is the only observational study design that directly investigates the risk of the disease and the factors contributing to it. And it is ethically safe. Multiple outcomes can be measured. They are good for rare types of exposures. Example, exposure at a chemical spill in a factory, not rare disease like we did for case control study. We have rare exposures, the risk factors. Now, disadvantage of this study is that it's not appropriate for rare diseases or those that take a long time to develop. For example, mesothelioma. It is not appropriate for studying multiple exposures and it can be costly and time consuming. So we are following these people for a long time, maybe 5 years. Some of them are following for 2 years. We are following for them months and years. It's so difficult and it's so time consuming, involving a lot of human effort. So, but this study design answers one of the best questions. Which clinical questions does this study best answer? It's going to answer about the risk. What risk factors predict the disease? This cohort study looks at dietary and lifestyle risk factors and investigates how they might contribute to hypertension in a woman. That's one of the examples, telling us that risk factors can be studied using cohort. Now, etiology. How can you determine etiology with this study? Like what factors cause these outcomes? The cohort study looks at factors in the early life that may predict the occurrence in adolescent suicide. So it's going to tell us the etiology. Prognosis. What happens with this disease over time? The cohort study examines the instances of recovery from the first time the episode of psychosis happened. So you're going to tell the prognosis. Then on diagnosis, we can ask if the test is positive, what happens to the patient? The cohort study examines recently released adults from prison who have been diagnosed with both mental illness and substance use disorder and investigates what happens to them following their diagnosis. So these are the best questions that cohort can answer. Moving on to randomized controlled trials. In 1747, James Lind, a ship surgeon, tested his theory for preventing the effects of scurvy by giving 12 sailors different dietary acids. He subsequently found that only sailors who consumed citric acid in the form of oranges and lemons improved. This was the very first clinical trial with 12 cohort of sailors. However, it's not randomized controlled trial, but that's the first clinical trial. So, in randomized controlled trial, researchers predetermined the eligibility criteria for the population considered for inclusion in the trial, resulting in a population that is reasonably similar in important ways. From here, a sample is taken. This sample are the trial participants. Now, these participants are randomly assigned to an experimental or a control group. This reduces the potential for bias and the impact of variables outside the researcher's control. Researchers manage the trial participants' engagement with the study, including exposure to the intervention of interest. This is the key difference to others, like observational studies where researchers do not directly expose participants to intervention. The experimental group is exposed to the intervention of interest while the control group is not. Both groups are then followed in order for a comparison to be made between their respective outcomes. Having both parties unaware of who is receiving what, the double-blinded structure is superior because it reduces the impact of these bias on the outcome of the trial. Let's have a look. So the clinical questions that this can best answer is, the randomized control trial can best answer effectiveness. Is a proposed intervention as effective as an established intervention, right? For example, we already have a drug treating heart failure, but they come up with a research telling us we have a better drug which can better treat the heart failure. So this study looked at the effectiveness of a play-based interventions for preschoolers with behavioral issues. Now, side effects. Does a proposed intervention have worse side effects than the established intervention? So this study looked at a medication intended to reduce blood loss after vaginal delivery. Cost of the treatment, like which intervention for a specific condition results in less cost to a healthcare service. So the study compared two methods of repairing aortic aneurysm. One of them has been less expensive, the other one is very expensive. So definitely we want to study which is less expensive. Patients' adherence to the treatment. So which interventions are patients more likely to positively respond to? This study looked at whether SMS messages improved adherence rates in patients receiving antiretroviral therapy. Right? We can always message them. The physicians have this, like they always message them that you can have only one dose of the drug. If the drug dosage is ended and the physician thinks that it has to be continued, they automatically get a message from the pharmacy, right? Your dosage has ended. You have to extend your dosage. So that's one of the things that you can adhere the patient to the treatment. Duration of effect of a treatment. Which interventions provide longer lasting benefit? This study looked at treatments for colorectal cancer and measured survival rates among participants. So you can have a duration of effect on treatment too. Randomized trials are advantageous in a way that randomization and blinding reduces the bias and impact of confounders. Confounders are variable which impact the outcome of a study and are outside the control of the researchers. Researchers have greater control over the study circumstances. They can lead to a strong conclusion. This has a strong answer about a causal relation between an exposure and features of interest. So it is very good trial. What are the disadvantages? The design, execution, and evaluation can be complex, costly, and lengthy, very time consuming, lots of money, lots of human effort. Recruitment of participants can be difficult for some research. We cannot tell them, come here, I'm going to give you an anti-cancer medicine. So they may not agree. It's very difficult to get people in the research. May not be appropriate for some research due to ethical concerns. For example, they could be pregnant. So we cannot have them in all of the research trials, right? So that is an ethical concern. May not be appropriate for some research due to difficulty of blinding participants for some intervention. Like for example, a person is having you think he's having a heart failure, you think this drug is good for the heart failure. It is not ethically possible for us to withhold him from having the drug, right? We cannot give him a placebo because he's already in a heart failure. You have to give him, right? Otherwise he may die. So that's one of the ethical issue with the randomized trial. In summary, the introduction to this clinical research method will provide students, as many of us, an opportunity to learn both the development and implementation of the clinical research study and a variety of methods utilized for sample collection and the study. Okay, so we have our first question here. 600 women aged 22 to 40 coming for routine checkup are asked about their smoking status. 15% of the women are smokers. Over the next 10 years, 12 smokers and 15 non-smokers developed breast cancer. Which of the following best describes the study design? I hope you all are not sleeping. I didn't make you bored, I believe. Yes. Yes. Thank you so much for replying. Yes. Yes. Correct. Thank you so much. Yes. So it's a prospective cohort study. So the scenario described above is a good example of a prospective cohort study. Initially, a group of subjects is selected like a cohort and the exposure status is determined, like are they smokers or non-smokers, right? The cohort is then followed for a certain period and observed for the development of outcome. And here the outcome in the question was breast cancer. Sometimes the exposure status is determined retrospectively and then patients are tracked from that point of time, typically using medical records. So yes, you all are right. Thank you so much. Next question. A study aims to investigate the effectiveness of the topical application of cotrimazole ointment in the prevention of surgical site infection associated with resection of advanced oral cavity cancer. 50 patients who underwent loco-regional resection were assigned by chance to receive standard care alone or cotrimazole ointment in addition to standard care. The participants were then followed for 40 days and the number and severity of the surgical site infections were recorded for each group. Which of the following best describes the study design? Awesome. Yes. 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 It is randomized control trial. Thank you so much. Yes, it is randomized control trial. A randomized control trial is an experiment in which participants are randomly allocated to more than 2 groups to assess the effect of specific interventions. For example, treatments. So here we use the cotrimazole ointment. Okay, so yeah, that's where I come to the end of my session. Do you guys have any questions?
I have one question for on the slide for the cohort, if you can show us that. I think
this one?
This one. The existing illness. Are these excluded from the study, or I couldn't understand this?
Yes, we have to exclude them from the study. Otherwise, it could be confounding, right?
Okay.
They all have gone to the past. Yes, we are going to exclude them from the study. They're gone to the past. We're going to start from the present and go to future.
Okay. Thank you.
Thank you for the question. Okay, yeah, let me just go down. Yeah, thank you so much. Thank you so much. I'm glad you guys didn't sleep. Thank you so much. Okay. Dr. Nadir?
Thank you so much.
It's a very interesting presentation.
Thank you,
Wasn't boring
Lina.
at all.
Oh, thank you so much.
Thank you so much, Ashwini. Dr. Ashwini, this is great and to the point. And very informative, very good, excellent. Thank you.
Thank you, Dr. Nadir. How do I stop sharing?
When you go up the screen, I think there will be a red. Yeah.
Thank you so much. Thank you so
You're
much.
welcome. Thank you. Thanks for a great presentation. Awesome. Any questions for Dr. Ashwini? Otherwise, Lena, go ahead.
I don't see any raised hand for now. Let me see the chat box if there's any question. Sarah is asking for the presentation to view later. If you can provide a copy of it, Ashwini.
Yeah, sure. I will, Sarah. So I will. We will do in the WhatsApp group, right?
Yes,
What
you
I
can share it
suggest,
there.
you can share with the WhatsApp group, but you can share also if you prefer as well. When you look in the app, you can go up there. Actually, I'm not sure if you can find edit file, but there is an icon here. You can, the plus, click it, number 2, I think, add file. So if you click that, it will update the information for you. If you want to add the file here somewhere, you can just upload it. If I can.
Okay, doctor. Yeah, thank you so
Thank you.
much.
If it's not working, send me an email and fix it. Thank you.
So next on our agenda, we have research ideas. If anyone has a new research idea, can share it with the group. I actually saw one research group being formed in the WhatsApp group. I don't remember by whom, but I remember it has something to do with pediatric. If someone can update us about it.
So Mafaz, Dr. Mafaz, I think, mentioned that.
I think Mafaz,
Yeah, so we are trying to finalize or organize an idea. She is interested in some pediatric question, but she wants to combine it to all the others, looking at COVID patients with pancreatic enzyme or some other component. Still working on finding the right approach or question. Any other ideas or projects that I know if you have any update, jump in. Mihir and his group are working on the long COVID. Shaza?
Assalamu alaikum.
Yeah,
Yes. Assalamu alaikum. How are you?
Good.
We made a research question. It's a relation between Alzheimer's disease and the chronic stress. And we made the WhatsApp group with 9 person, and we start to search about the article about it, and we'll let you know about the progression.
Excellent.
Yes,
Good.
thank you.
Great. Thank you for sharing, and good luck.
Thank you so much.
You're welcome. If you have questions, let me know. All right. Arij, go ahead. Arij, I know you sent me an email. You have questions still. We are working on.
Yeah,
I
can just briefly. I still haven't posted on the group because I still not sure if it's possible, but I did talk to Dr. Nadir about doing a research idea along the line of the association between mild cognitive dysfunction, what electrolyte imbalances are present among nursing home residents with mild cognitive impairment who are otherwise asymptomatic. So if anyone is interested, it still isn't confirmed.
Before we. So I just wanted to touch base with you, but we can discuss it here. So I know we said we discussed like the meeting will be 2 hours, but maybe we will extend it a little bit. If anyone wants to go, that's fine. You can review the recording later. But regarding a rich idea is looking at patient with cognitive problem and looking at electrolytes. It's a good idea and it's can be done, but it will take some time. So when you have a question and you want to find information for that question, think about the method, the variables that you want to collect, and how you can do that as far as time-wise. Last time we discussed about patient at the hospital. At the hospital, it's easier because the whole system, the patient diagnosis list and variables like vitals or lab or X-rays, you will find it automatically if you run a report. Let's say I want all the patients who are in the ICU with positive COVID. So the IT team will put this information, they will collect it within a minute, they will give me an Excel sheet with all this. The problem with nursing homes, they have a different EMR, electronic medical record. They have X-rays from different companies, labs from different resources. So the information distributed or from different components is not in the facility. You can get it, but not automatically. You cannot run a report and collect information. You will need to go chart by chart. You will open the chart for that patient and go over all the information you want to collect. And if you need, let's say, to get the lab, you have to go to another area in the file where you will look at the lab result and then collect it from there. So it will be labor intensive kind of approach. It will be manual. You need some person to go in the chart and collect information and put it in your spreadsheet or your data collection file, which can be done. But as I said, you need people to work on that. It's a personal, it's individual, like it's a human operation kind of. It's not electronically or by computer can generate a report, which is, I don't think it's an approach for you guys to think about it when you want to do a project to finish it within the next couple of months. This is my thinking. When you are a resident, you can do that. You can look at files at the hospital because it will be faster. All the information will be from one source. If you are in a nursing home, you want to do that, you have the time, so you don't have limitation as we are here. So my approach is maybe you think the same question, but from a systematic review, look at the literature, see if there is anything there that you can collect information and see if you can come up with an answer, and then we can take it from there. Or maybe you can have the answer, but you want to come up with a different question from these answers that you find. If I'm making sense for you, Erich and our group. Go ahead, Meher, and then Shema.
Thank you, Dr. Nadir. So from long COVID project we are working on, some updates about it. We just had our first Zoom meeting prior to this meeting. And even though long COVID project was a ongoing project, we're going to start over. We're going to do some changes into that, and we're going to focus on systematic review and more on geriatric population. There was a previous one had an abstract of comparing young population versus geriatric, but we're not going to focus on that. And we have we are right now working on a research question. So once we get that point, and then we'll go from there. So that's it. Thank you.
Good. Thank you for that. Thank you so much.
You're welcome.
Yeah. Go ahead, Shema.
Hello, Dr. Nadir. Hello, everyone. Me and 9 colleagues are working on the research topic that I sent you earlier, the systematic review of diagnostic modalities used to capture prodromal Alzheimer's disease. Actually, we're looking or I'm thinking of looking for 3 main items: the neuroimaging, the MRI, and genetics, and cerebrospinal fluid biomarkers. To the main objectives is to diagnose early, so patients can have the chance to get benefits of the disease-modifying agents, or even participate in trials that can help or have promising for a future treatment. So we're still working on it. Tomorrow we're planning to have our first kickoff meeting to discuss and share information and thoughts, and assign roles, who's gonna do what. So I will keep you updated.
Thank you so much. Sounds great. So excellent. So for the new fellows and who didn't join us last time, so we have the idea is to divide the groups into teams where we can just divide the task for the fellowship. Like every week we will assign one team to do certain things, and the week after another team will do similar things. Similar to the discussion today, like the presentation will be done by one team. This is just for organization and to give everyone the opportunity to participate, and also to know some of you might have other obligation. Let's say some of the fellows are preparing for step 3. So the team leader will identify, oh, you are preparing for step 3. So we will wait for you next time you're gonna participate. We will let you prepare for the test, something like that. So for me, it's not gonna be overhead as far as know which one is doing what and contacting you at the micro level. So the team leader will handle all organizational stuff between the team. So this is one part. The other part is the teams per project. So some of you might come up with an idea for a project and discuss it, and then people might be interested. So he or she will be contacted by some of the fellows. So they will create the project team. So one person will be the team leader for that team project, and then they will assign the task for each one of the team members. And then when ready, you can contact me, and then we can work on getting it finalized and to the next step. Let's say we want to make it a poster or abstract. We identify which area we can submit it to, and then take it from there. So these are the 2 approach as far as organization or team work. Thank you. Me here.
Hello, sorry to interrupt, Dr. Nadir. So just wanted to add a little bit more onto our project. First of all,
sure.
When I said we earlier, I meant group members with Dr. Ala Abdel Samed, Dr. Ryan Muhammad, and Dr. Ryan Salih. We are 4 for now, and if anybody is interested to join us, they are more welcome to do so. Either just email me or Dr. Nadir, and we'll get you on our board. So thank you.
Sounds good. Thank you so much. If Ala is there, maybe can you update us as far as your preparation for, I think it's next week?
Yes. Yes, actually, in the May 18, it's going to be I will present the posters in Ohio, Cincinnati, and I'm so excited to go there.
Good, excellent. Good luck. So this will be the second poster presentation in person. So thank you, Ala. Last one was done by the person now, and that went also great. So we wish you all the best. I have Huzaifa, Lina, you're welcome. And maybe Huzaifa, if you have a question, or Noreen, if you have a question or comment. Doa, go ahead. Salah.
So, doctor, regarding the numbers of individuals per project, what's the maximum number?
So we target about 10. We think that's a manageable number for a project. In areas where the project might be, let's say, has a good impact and it has a lot of work, the number of people involved might be larger than 10. But most of the time, we think 10 or less might be appropriate for each project. Thank you.
Thank you.
And I want to share with you not only thinking about ideas for project, let's say, as far as research-oriented project, but I want to share last year or the year before, last year, we thought about educational part for our community. So some of you work together, and that's from the first batch and second batch, and they come up with the idea of a webinar for COVID vaccine and hesitancy and education, something like that. So what they did, they created a questionnaire for doctors in Sudan and some of their families, and collected some information about what they want to discuss during the webinar. When they collected all the information, they identified, let's say, 7 of the fellows that will present that webinar, and they divided the task. Each one will present part of the discussion, and they delivered that. And we worked in alignment with SAPA, Sudanese American Physician Association, together. So my thinking is maybe for the next coming months, maybe you can also make some groups or ideas about education in the community in the area, in the country here, or overseas. Let's say you have some of you presented in Saudi Arabia, let's say. Maybe you can get together and think about what's the best topic to discuss and present as a webinar of the community there. If you find some topic, maybe you can discuss and see who's interested from the fellows to join, and then make a group for that project. Just think about it. Thank you. If you have any comments or any questions, go ahead. Lena, you can take it from here.
Actually, there's one suggestion from my group for next meeting. Since the topic of presentation and posters came up, they want a presentation about how to make a poster. What are the steps and how to present a poster in a conference. So if that could be presented by next meeting team, it would be great.
Okay, thank you. This is a great
Anyone has
idea.
another suggestion? I will share. Yeah.
So speaking for next week, I just added some names and some topics. Maybe we can just, if you can help me remove or edit or add to the list. So the first topic, maybe we can talk about nutrition and weight change. If both presenters will work on this, it's a file that can be found in the app. They can work on that. Followed by another topic about dentition, oral health. We have Dr. Sahar, she is a dentist. Maybe she can talk on that. Maybe she's not in the same group or the same team, but she is, if she's available, she can talk about that. Then we can continue on the study design and variable, how to collect this information. Maybe some of the other team members can join. And these names can be switched or changed. The team leader can work on that. And then, as you mentioned, maybe poster presentation or preparation. Does it make sense, guys? Or if not, let me know. So most of you use WhatsApp as far as communication. Maybe Meher is working on leading the team for the long COVID. He put his phone number on the chat. If anyone is interested, you can contact him. All right. Mafaz, go ahead. You have a question or comment? Go ahead.
Yes, regarding my topic, it's about the incidence of pancreatic disease and COVID patients in comparison to geriatric or older adults and pediatric population. However, my question is, if I was to, or like if pediatric candidates interested, if they were to make a research about pediatrics only, is it possible or is it?
That's possible. That's possible. So again, the way we work here is to teach you or maybe give you the opportunity to learn and learn more skills, knowledge about the research, how it works. If you don't, or if you have some skills, maybe you can just sharpen and improve your skills. You can apply that to, let's say, pediatric or any disciplines, let's say neurology or other. So you will learn the how to, and you can apply that. The only question is the title of the fellowship is geriatric. So when you apply and they interview you, they will say, hey, it doesn't make sense. You are applying to pediatric, but you are doing geriatric medicine. And for that, you can answer whatever answer you might have. But I think the best answer is to tell them, I wanted to work on my clinical, my research skills, and I learned so, I worked on so, and I did so. If you are involved in some of the projects. So I think the idea initially is just geriatric, but if you have a group who are interested in pediatric, you can do that, and you can work on whatever project you want to. It doesn't have to be in geriatric or related to geriatric. The other answer I will advise you to give is that even if you are dealing with kids, at least here in the US, you will deal with their parents and their grandparents. So at least you will have some idea about what's going on with the family, and you can answer some question or advice to the older parents or grandparents in the family. Thank you.
Thank you.
You're welcome. Any other questions, comments before we go ahead, Lina?
I don't see any raised hands. And I think we went through next meeting agenda, right?
Correct.
There is no more suggestions for topics to be added. And the chat box is free of questions.
Okay, sounds good. Thank you so much, Lina, for moderating the Zoom meeting. And thank you all the presenters, and thank you all the fellows for your participation. And I wish you all the best, and we will see you next week. Have a great day, or night, or evening, wherever you are.
Thank you so much.
Thank you so much.
Thank you.
Thank you.
Wonderful one. Thank you.
Thank you so much, Dr. Nadir.
Thank you.
Yeah, everyone.
Thank you
Thank
so
you,
much.
Dr. Nadir.
Thank you, Dr. Nadir. Good night.
Thank you so much. Have a good one. Thanks.
Thank you, Dr.
Thank you, Dr. Nadir.
Thank you, Dr. Nadir. Have a wonderful day, guys. Bye-bye.
Thank you.
Thank you, everyone.
Thank you, Dr. Nadir, and everyone.
Thank you, Dr. Nadir. Have a good evening.
Thank
you, Dr. Nadir.
Thank you.
Thank you, Dr. Nadir.
Thank you.
Thank you.
Thank you, and have a wonderful one.
Hello, Dr. Nader.
Yes. Hello, Dr. Ryan.
Yes, I just have a quick
Go ahead.
question.
Yes.
So I'm a part of the yellow team, but the yellow team is not going to be presenting until another few weeks. My question to you is there an opportunity for me to present during one of the weeks with the other colors if I reach out to the team leader?
Oh, sure, yeah.
Okay,
Sure.
thank you so much.
So it's just organizational, and if you want to reach, approach them and see.
Okay, I appreciate that. Thank you so much, Dr. Nader. I'll also reach out to you and let you know what ends up happening.
Sounds good.
Okay, I appreciate
Thank
it.
you.
Bye.
That's